directly to the... Yeah. Okay. Thank you very much. It's a real pleasure for me to be there, and as an honor. And I would like to thank Mark and the organizing committee. So what they asked to do is just a short live demonstration for the upper extremity nerve, half an hour, more or less, and then to move to the pathological changes with a PowerPoint presentation. So if you agree, I can move over there. So when, a little bit this way. When you start examining the nerve, the first thing is the most difficult just to locate exactly the nerve, because you must have a very, very good knowledge of the anatomy. So what I do usually, I try to focus on the one region in which I can locate exactly every nerve, and I can move then up and down with the so-called elevator technique, just to following each nerve. So from the arm, I believe the best thing is just to start with the elbow, the region of the elbow. At this level, you have, this one? You have 3 main nerves. The radial one, which is located on the radial aspect, so it's so easy. Voila. The zoom. This one. You move a little bit medially, and you can find the medial nerve. So 2 nerves in the anterior aspect. The medial is the medial nerve, and the lateral is the radial nerve. And 1 nerve on the posterior, the ulnar nerve. So start a little bit with the medial nerve, which is most famous. It's so easy to detect it because it's close with the humeral artery. So you find the humeral artery, you find the medial nerve, which is closer located, used medial to the artery. So you can follow a little bit in this way. And in addition, you can locate, once you have located the artery, the nerve, you can locate this muscle, which is the pronator teres muscle, and this is the anterior brachialis muscle. So the nerve is in between the two. And if you move a little bit distally now, to the level of the forearm, you can follow the nerve. You can see the pronator teres going up, and the brachialis which become thinner and thinner because it inserts in the cubitus. So you can follow the nerve. You have to put the focus a little bit deep. You can follow, and you can see the pronator teres on the top of the medial nerve, and you have to adjust every time the transducer perpendicular to the nerve. This is automatic. So you can see the typical appearance of the fascicle, which are dark spots surrounded by a white connective tissue. So once again, and down. And so you can follow this nerve, which is located in the middle. Median means in the Latin in the middle of the forearm. And is located in between the superficial, the flexor digiti superficialis and profundus. This is the flexor digiti superficialis, this is the profundus, and this is the nerve. When you move a little bit distally, you can follow the nerve, always running in between the 2 muscles to the level of the carpal tunnel, which is very well known by everybody. So I go up again, and I will spend a little bit moment in discussing the relation of the nerve with the pronator teres and the flexor digitorum superficialis. Once again, the pronator teres, we follow the muscle now. And you can see the muscle which inserts in the radius. So it's a long muscle. It's a long muscle. Back to to the nerve, and now I follow the nerve, and this is a particular point in which you can see the flexor digitorum superficialis, this one, the muscle, and the nerve, and this is the arcade of the flexor digitorum superficialis. So this is one of the potential site of compression of the nerve. Maybe we can lower a little bit the light, please, for the screen. If I make a longitudinal image, so I start with the axial, up and down elevator, then I move to the longitudinal. I just swift the transducer over the nerve, and you can see the nerve over there. You move a little bit and you find the artery. Once again, the nerve. When I follow the nerve, I can follow the nerve longitudinal. The nerve can become deep and deep. This is the pronator teres muscle. Then I move a little bit, and this is the most interesting area. This is the flexor digitorum superficialis, and this white area is the arcade. So if you have a compression over there, make axial and longitudinal, and this is the muscle. You can see very well. Look to the nerve, which is quite pretty. No problem at all. Regular fascicular pattern, no changes in the size. So it's completely normal. And you can follow now in the distal, if you want, by longitudinal. It's very easy at this level because you can see the nerve in between the two muscles. Once again, you can see the fascicles, which are parallel at this level. It's not the same, more proximal. Distal, the fascicles are quite parallel, so it's very easy to follow that. Let's move now to the radial nerve. So from the medial, I move a little bit to the right to the lateral part of the elbow. And once again, the nerve is located between two muscles. This is, once again, the anterior brachialis, and this is the coracobrachialis muscle. And at this level, the radial nerve is split in two. This is the posterior interosseous, and this is the superficial branch of the radial nerve. If I move a little bit distally, you can see the two nerves which divide superficial, a small artery, interosseous, and you can see here the deep motor branch going deep, deep, and this is the arcade of Rose, this white line. So this is the nerve going in between the two heads of the supinator muscle. And if I move a little bit more, you can see now the nerve which is in between the two muscles. And this flat appearance of the nerve is normal. It is in between the two muscles, so the size and is a flat appearance. And then I move a little bit more distally. I can follow the nerve, which is here, till here. You can see the small nerve going out the supinator muscle. And you can follow the nerve just to the muscle, the extensor muscle. So a motor nerve. Then I go back once again, my nerve, I go back. And this time, I will follow the sensitive. The sensitive is very easy to be followed because it is located under the coracobrachialis muscle. So if you find the muscle, you can find the nerve. If you can find the nerve, you can find the muscle again. Huh? So this is the coracobrachialis, and this is the superficial. And we move distally, the coracobrachialis, the nerve again, the nerve, and the artery, radial artery. Once again, you can see the coracobrachialis become thinner and thinner just to be replaced by a tendon. Look, this is the nerve, and this is the tendon of the coracobrachialis. And the nerve is still on the inferior aspect of this structure. If you move a little bit again, you can see the nerve more or less passing in between the two. I have just to zoom the image. And to rise the most possible. Okay. And this is my arrow. So once again, look at the nerve. This is the nerve, the tendon, the nerve, going in between the two. And this is the nerve, which goes superficially. So it can be followed after to the level of the crossing with the tendon, extensor tendons of the wrist, the first compartment. We can do that. We can try to locate the nerve and follow to the crossing. This one, this one, this one, this one, and look to the, going on the other side. This one again. This is a tendon of extensor, first compartment, and this is the nerve, running close to the retinaculum. If I move a little bit from the elbow proximal, I reduce the zoom, and I'll find my nerve. I move a little bit proximal, and I can follow. Now you have a single nerve, the radial nerve. And I can follow it close to the level of the middle third of the arm, running close to the cortex of the humerus in the radial sulcus. And if I move a little bit more, there is an artery on posterior hasp and the nerve. And this is the cortex of the humerus. And you can move on the arm to follow this. So you can see that the elevator technique works very, very well. So you locate a nerve in an exact level, and you follow up and down. Then we move to the ulnar nerve on the posteromedial aspect. We have to examine in this position, a little bit flexion, and we'll put some gel on the posteromedial. So once again, I start to the level of the elbow. We have to zoom a little bit. Can I zoom a little bit? And you can find the olecranon on the left and the epitrochlea on the right. And the ulnar nerve is located just between inside the tunnel, the cubital tunnel. It's quite easy to find it, but if you move a little bit, you can follow the nerve in the arm, which is very superficial. And then you go down, following this nerve. It's quite on this position. It's not on the deep part, never. Always very superficial. It's a little bit difficult to locate. I will put a small amount of gel up. And this is the nerve. And I follow distally, and you can see the two heads of the flexor carpi ulnaris muscle and the nerve running in between the two. And you can follow now in the forearm. You can see the nerve over there, the nerve over there, and now at a certain point you can see the ulnar nerve coming to join the nerve, distally, and we wait for the ulnar artery, which is here coming, and to run close to the nerve, and I can follow. This is the flexor carpi ulnaris muscle, the nerve, the artery, and I can follow it just to the distal. And once again, the tendon of flexor carpi ulnaris, the muscle, the nerve, and the artery. So I usually look for the ulnar nerve on the arm, the capital tunnel, and then I move in this position to look to the Guyon tunnel. So I try to locate my nerve over there, the artery, so I'm sure I can explore every segment of the nerve, the artery coming from the deep, the nerve, and I can move on this way. And I can follow the muscle, which becomes thinner and thinner, smaller and smaller, and the tendons become larger and larger. At a certain point, you can also appreciate other structure, in particular, this one. Look, this is the ulnar nerve, and this is the dorsal palmar branch. We take origin from the ulnar nerve, and it runs in between the flexor carpi ulnaris and the pronator quadratus muscle. So this is the branch, the sensitive branch from the ulnar part of the dorsum of the hand. And you can follow it. And then you need to change the position. You can follow it also on the dorsal aspect of the hand. So as you can see, it's quite easy. The only things you have to do, just to know the anatomy, to make always the same examination, standardized examination, to start at the level of the elbow, and then to go up and down. And with time, we can recognize all other structure, the artery, the veins, and all other structure. And with the time, you can also recognize other small nerves which are located in the upper extremity. This one, I am at the level of the middle third of the arm, anterior aspect. You have the humerus, you have the brachialis anterior, you have the biceps muscle. And this is a nerve running in between the two, which go farther. You can follow it. And you can see going to the subcutaneous tissue as the lateral antebrachial cutaneous nerve. This is the musculocutaneous nerve, which is very thin if you want. It's not so easy, very thin, but you can locate it. You can see it. And if you can go up, up, you can follow it, you can follow it, you can follow it. It becomes larger, 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 and you can follow it to the axilla if you want. So there are also other nerves you can locate depending on the clinical situation. And with time, we started to recognize every single subcutaneous small nerve, which can be injured in a lot of our conditions during venipuncture. They could be injured, so you can do that. So do you have any question? I don't know if you are right to some question, yes or not. There are one nerve, everybody asks me, show me the anterior interosseous nerve. It's so difficult. The anterior interosseous nerve comes from the median nerve at this level, and is so thin and so deep that it's quite impossible to locate it. I don't know if this is one, the small one located close. Anyway, if there is swollen, you can see it. If there is a mass, you can see the mass. So it's the most difficult, in my mind, it's the most difficult nerve to be located. It's 1 millimeter, not larger than that. It is deep. Any question? Yes?
Could you just show us the palmar branch, the ulnar?
Sorry?
Could you show us the deep palmar branch?
Ah, yes. The Guyane tunnel, you see? Yeah. Sorry. So we zoom a little bit again. We move. And so for the Guyane tunnel, you must first locate the pisiform. If you locate the pisiform on the human aspect, you have the carpal tunnel, you have the median nerve, you have the scaphoid, you have the flexor carpi radialis. Okay? So I am cutting at the level of the proximal carpal tunnel. You locate the pisiform, you can see here a small part of the tendon is a flexor carpi ulnaris tendon going over the pisiform, like the quadriceps go over the patella. It's exactly the same. You have the artery and you have the nerve located in between the artery and the pisiform. So I can follow this nerve here, and you can see at this level the splitting of the nerve. This one is the deep part. This is the nerve, and you can follow this part of the nerve which go medial to the hook of the mate. This is the hook of the mate, and this is the deep branch of the ulnar nerve. Then I go back again, and I follow now this part, which is the superficial, that go on the top of the hook of the mate. It can be injured by repetitive compression over there. This is one nerve. The second is there. This is for the fifth, and this is for the first finger. And this can do in every patient. It's not the same with the sciatic nerve. It depends on the tissues. It depends on the habitus of the patient. On the upper half, you can locate every nerve in almost every patient. Almost every patient. I show you just the median nerve. You see this small branch. This is the sensitive branch of the median nerve. You can follow this. This is the flexor carpi radialis, and you can follow the small branch, which is located at distance of the median nerve. This is quite important after surgery of the carpal tunnel syndrome. They can be injured during surgery, and you can follow close to the flexor carpi radialis. So with time, you can recognize every small branches of the nerve in the upper arm. So if you agree, we can move to the PowerPoint presentation just to look through some pathologies in the arm, elbow, and forearm. Thank you very much. Can I load the light, please, over in the first, if possible? No, lower. No. So we will go from proximal to distal, looking for the median, radial, and ulnar nerve, and trying to show you a wide range of pathologies which can affect the nerve. Start with the arm. The radial nerve, as we see a few minutes ago, the nerve runs close to the cortex of the middle third of the radius. Inside the groove, together with an artery, the posterior humeral artery, as we saw a few minutes ago. The nerve is located in between the medial head of the triceps muscle and the lateral head, which cover the nerve. So at this level, the most important and most frequent problem is the radial sulcus syndrome. An impingement, compression of the nerve in the radial sulcus, usually because of a fracture of the midshaft of the humerus. As in this case, this is an axial image. You can see the nerve, which is a little bit larger, the humerus, and a fracture over there. Typical deficit of extension in a young lady from Holland with a fracture over there. And you can see the nerve is surrounded by this regular hypoechoic area. If you make a longitudinal, you can see the nerve here running over there, the fracture over there, and the hypoechoic area which surrounds the compressed nerve. There is not a large changes, not a huge changes in the nerve, but there was the deficit in the extension. And this is the typical appearance of the callus, which is not yet calcified, compressing the nerve. Very easy to do that by ultrasound. There is no problem at all. So non-ossified callus is a little bit easier if you have a large nerve and you have some hyperechoic material in contact with the nerve, compressing the nerve, as in this case. But this is quite easy to do the diagnosis on the X-ray if you have the clinical findings together. The most important things of ultrasound is to judge after surgery. There is no problem at all with the material, the orthopedic material. You can do that. MRI is impossible. CT is useless. And look to this patient that comes with a problem in the radial nerve after a fracture, which was treated by surgery. Once again, this is a clip. I move from proximal to distal. This is the humeral shaft, and I move a little bit. This is the radial nerve. It's large, hypoechoic, very regular. And I move a little bit distally, and you can follow the nerve. And I can see here, up, one, and here, hop, two, which are quite typical, very typical appearance. I move on the longitudinal. You can see here the screw going out the cortex and impinging in the radial nerve. You can see one screw over there and one screw over there. And if I see the nerve is close to the screw, but the most important thing is to make some dynamic examination. So I ask the patient to contract, to make every movement, to contract a muscle, to see the relation of the nerve with the screw, just to be sure. because after the surgeon asked me which screw is responsible for the impingement, and this is quite easy to do that. You have axial, the nerve swollen, hypecoic, and I contract the muscle, and you sink the screw over there. The second one, you can see the nerve going up and down, impinging against the screw. So there is no doubt adopt. So the screw is the problem, the distal one, and the nerve can follow the nerve which impinge against the spires of the screw. Up here, up and down, up and down, up and down, during the movement. So there is no other way to image this impingement syndrome. Always on the arm, a problem, schwannoma. So you can find schwannoma everywhere, nerve fibroma everywhere. The distinction between the two is not possible, to my knowledge, by ultrasound examination. This is the ulnar nerve axial again. I move, you can see the fascicle and see a tumor which is located inside the nerve, hypecoic tumor and the nerve distal to the tumor, and again up with the tumor. And in this particular case, you can see all the fascicle which are displaced to the periphery by the tumor, which is highly suggestive of schwannoma. And you can see the surgeon most probably is a schwannoma. If you do the longitudinal image, you have the nerve over there, and you have this mass which is located inside the nerve. You can see the fascicle of the ulnar nerve. This is 1 centimeter from here to here. And you can see the fascicle, and you can see the nerve. You can judge the sides, you can judge the borders, you can judge which feels inside or outside the nerve, and we can judge the vascularity of the tumor. Hypervascular, fascicle located on the periphery, this is most probably a schwannoma. Going to the elbow, the anatomy, brachialis anterior, once again, the medial muscle, biceps, the tendon, the lacertus fibrosus, the expansion of the tendon, distal tendon of the biceps, the artery, and the medial nerve. So the compression of the medial nerve can be at different level, at the level of the elbow. The first one is the lacertus fibrosus. It's very rare. I never saw that, never seen. The second one is the pronator teres, because it runs just below the muscle. The third one is the sublimis, the fibrous arcade of the flexor digitorum superficialis. Compared to carpal tunnel syndrome, compression of the medial is exceptionally rare at the level of the. I show just one case, a compression in the flexor digitorum superficialis arcade. You can see on the longitudinal and on the axial image the normal medial nerve, swollen nerve, and normal medial nerve. And this is in the axial. If I move on the axial, this is the nerve. I move distally, a swollen nerve over there, and then I move on longitudinal, which corresponds exactly to the image on the right. And if I do a little bit slower, I see the nerve, which is normal over there. It is compressed over here by the muscle, flexor digitorum superficialis, swollen, and again, on the distal is completely normal. So every time you do that, you have to compare to clinical findings. This is really necessary, the only things that can work. The ulnar nerve comes down on the posteromedial. It can be compressed at the level of the septum, intermuscular septum of the arm, at the level of the retinaculum or the arcade of Osborn. There is a lot of confusion in terminology, also in anatomy. Some people talk about the retinaculum, including the Osborn arcade. Other differentiated to structure. It's not so important for ultrasound. This is my dissection. You can see the retinaculum, and you can see the two heads of the flexor carpulnaris muscle, and this is the Osborn fascia, and the nerve running just below the fascia. The ulnar nerve in extension, there is no problem at all because the retinaculum and the fascia are relaxed. So there is no problem. The nerve have enough place inside the tunnel. When you make a flexion, there is a change in the retinaculum, in the fascia. The nerve moves a little bit anteriorly, which is less space from the nerve. And so the nerve can be compressed by this stretching of the retinaculum and the fascia, which can be seen also in ultrasound during the movement. You can see that. In addition, there is a bulging of the medial collateral ligament of the joint, and there is an anterior protrusion, small anterior protrusion of the triceps muscle. On the flexion, sometimes there is no retinaculum, it's a normal anatomic variation, or there is a term the reticulum, allowing the nerve to displace anteriorly. So every surgeon asks you, is there a compression of the ulnar nerve? Is this located in the cubital tunnel? Is this the nerve unstable, yes or not, anterior? This is quite rare. It's a compression of the septum, so to this level. You can see the nerve coming down. The septum is very difficult to be seen. It's this structure. If I do a dynamic examination, I can see the nerve coming down, going on the septum and going on the other side up. With a sort of click, it is swollen over there. Once again, anterior and then up posterior and swollen over there. And if you move a little bit distally, really swollen, you can see the fascicle inside. To the level of the tunnel, the nerves becomes normal. To the level of the tunnel. So once again, the elevator technique. A compression in the septum. Instability of the nerve, so this is the normal situation, no instability, instability. And you can see in an axial image during flexion of the elbow, the nerve which go outside in this way. It's quite easy. You must not compress too much with the transducer. Just ask the patient to do this movement, following the nerve by axial play. And this is a typical example, swollen nerve, no fascicular pattern inside, hyperechoic, and I move on flexion. Tuck. It was very, very easy. So this is one step, and you can have two dislocations. First, the ulnar nerve, which is here. So during flexion, you can see the nerve going on the other side. Tuck first, and then this is the tendon of the triceps, which go up on the other side. So the double click. First the nerve, and then the triceps, which is quite important because it's surgical. You can operate by removing a part of the triceps muscle usually. So you must know this in the report. Accessory muscle located inside the tunnel. Typical example, Anconeus epitrochlearis. You have here the nerve. I move a little bit from proximal to distal, and I can see a muscle located inside the tunnel, this one. The nerve, the bone, olecranon, and the muscle. If I look to the normal subject, the nerve, I move down to the tunnel, is the other side, and you don't see any muscle inside the tunnel. So you must judge if there are muscle, yes or not, and the size. You can see on the axial, and you can judge also, this is the muscle, on the longitudinal. You can see the ulnar nerve and the Anconeus epitrochlearis muscle located superficial to the nerve. And you can move one side to the other side just to judging this muscle. And you can compare on the other side, no muscle on the other side, the nerve, once again, no muscle. The muscle is here, no muscle here. So we can see the surgeon, this is a muscle, accessory muscle. I don't know really if this is compressing, yes or not, the nerve. It's very difficult to do that. but you can see the size, exact size of this muscle. Post-surgical compression inside the tunnel. Once again, a huge nerve, hypoechoic, and you can see here the plate, osteosynthesis plate, from proximal inside the medial epicondyle, the petroclea. And you can judge also if there is some instability, yes or not. This is the nerve. During deflection, the nerves go over the orthopedic material and then back inside the tunnel. No other way. MRI is impossible. CT useless. So the only way to judge is sonography. And when the nerve moves, you can compress a little bit just to look for retinal sign. With your transducer, it's very useful, very, very useful. Exactly my pain, doctor, when you compress. Osteoarthritis, again, a mass inside the tunnel, the nerve, swollen nerve, compressed at this level by the changes in the osteoarthritic elbow. Look at the very thin nerve at this level, the site of the compression, and very large nerve proximal. On the longitudinal, you have a swollen nerve inside the tunnel and complete normal ulnar nerve in the proximal part of the forearm. Very swollen nerve at the level of the retinaculum and Osborne arcade. Another example, a swollen ulnar nerve, some calcification, some thickening of the capsule in osteoarthritis, explaining the compression of the nerve. In idiopathic compression, usually the site of the compression is the Osborne arcade over there. You can see and you can detect exactly the level of the compression. This is the swollen nerve, proximal and distal, and this is the arcade of Osborne, and this is the normal nerve distally. You can say the nerve is compressed at this level. You can mark the skin if you want. This is the MRI, which is very difficult to make a longitudinal image over the nerve. It's very, very difficult. You have to spend half an hour just to find the correct plane to cut the nerve longitudinally, 2 seconds with ultrasound. And this is a clip look. Pathologic nerve, normal nerve. Is the black and white. And if I move, you can see here the flexor carpi ulnaris, and this is the Osborne arcade, the white structure. And the compression is over there. There is no doubt. This is the axial image, and this is the MRI image of the swollen nerve proximal. The radial nerve at the level of the elbow, as you can see a few minutes ago, the supinator muscle, the two heads, the deep and the superficial, the nerve coming down, splitting into the posterior interosseous, which runs in between the two heads, and the superficial, which go superficial to the supinator and deep to the brachioradialis. So this is the typical longitudinal image over there. You can see the supinator, the superficial, the deep, and the superficial. And the arcade of Rose is usually located over there. So it's thick, it's fibrous. This is the problem. If this is only muscle, there are no problem at all. So if you have a Rose arcade, this is the fibrous, it can compress the nerve. This is the Rose arcade, the nerve going inside, between the two muscles. Interosseous, between the two, as you see a few minutes ago. So entrapment neuropathy can be at a different level of the posterior interosseous. The first one is the recurrent radial artery. This is the humeral artery. There is a vessel and artery that go on this side, is the recurrent. And usually the artery runs deep to the posterior interosseous. But sometimes it runs superficial, and it can compress the nerve. First. Second, Freud's arcade at this level. Third, compression of the distal arcade, which is not well known. It can be also over there to the exit of the tunnel, a small fibrous arcade that can compress the nerve at this level. It's quite uncommon, but it is well described in the literature. So start with the recurrent radial artery. Once again, a clip from proximal to distal. You can see the nerve, posterior interosseous. You can see the artery that go up the nerve, not below, and go on the other side. You can see this on the longitudinal. You can see here, this is the nerve, the posterior interosseous nerve. This is the artery, and this is the compression of the nerve, which has a clinical explication. Otherwise, you can see this is a compression. The patient had a posterior interosseous syndrome. The nerve cut in the longitudinal, the artery cut in the axial. And this is the color Doppler. You can see one artery here, two arteries here, and the nerve which is compressed. We move to the froze arcade, as usual, dynamic examination. We examine the nerve always in this position, without any muscle activation. And this is the nerve coming down, entering in between the two heads. The superficial is here, as you can see in the drawing. The deep is here, and the nerve runs on this way. And you can see the nerve going inside the two. And this is the froze arcade, the white area. But if you do that, a resisted supination, so you ask the patient to activate the supinator muscle, you can see this aspect. This is a squeezing of the nerve in between the two. Relax, linear, compression, activation, and you can see the changes in the nerve when it enters inside the two muscle heads. There is no description, at my knowledge, in the literature of this test. And I believe that, ultrasound is dynamic. You have to do that every time, from every condition, for every pathologic condition, for every structure. A swollen nerve. The arcade, a normal nerve. So typical compression of the posterior interosseous nerve, very, very swollen. And I push a little bit with my transducer to make a thinner side. This is the axial, a very swollen nerve here in between the two. Large, huge swelling of the nerve. The nerve can be compressed by idiopathic, because you don't know. Maybe some muscle hypertrophy, maybe some repetitive movement in supination, or it can be compressed by some masses. The most frequent are the mucoid cysts. There is a synovial recess over there, which is called the proradial recess, and cysts can come from this recess. Mucoid cyst, you can see the radial head, as in the drawing, the cystic lesion, the septa inside the cyst, and you can see in this case there was no compression, but you can see the nerve here, and you can see the cyst over there. And the nerve is straight, there is no compression, no dislocation, but the cystic lesion is just to the contact of the inferior aspect of the nerve. So you can realize how easily can be compressed the nerve in this case. Paraosseal lipoma is quite unusual, but is well known. It's a lipoma that comes from the periosteum. This is a lady which was sent to me, is the wife of my orthopedic surgeon, one of orthopedic surgeon. Tendinitis, tennis elbow. Hopefully, nothing in the tendon. I move a little bit distally, and I can see a large mass, hyperechoic mass, located inside the supinator muscle. So it was discovered it was sent for diagnosis really of tennis elbow. And this is the mass, which I move a little bit. You can see this is the head of it. And when I make plain films, you can see very nice. You can see the lipoma located exactly in the region of the mass, which I discovered by ultrasound. And if you like the details as I like, you can see this small fat stripe, which is the supinator fat stripe, which is the fat which is located over the supinator. So you can say the mass is inside the supinator, in the X-ray. This is the longitudinal, you can see, look, this is the nerve coming and pushed against the frozen arcade by the lipoma. And you can see the nerve here. Up, swelling nerve over there, compressed over there. And you can see that the lipoma also is made like, what is the term in English? Clockwise, no? It is, what is the term? It's compressed, the lipoma. You can see against the and this is the axial. Nice. Look to the nerve. It's very thin, and then huge enlargement of the nerve. And since it was the wife of my friend, I performed the MRI, is exactly the same. You can see the lipoma arising from the deep aspect, from the periosteum, and this is maybe, I don't know, the nerve, and this is the first arcade. And the lipoma, which is compressing itself against the first arcade, compressing the nerve. And this is the axial, a little bit distal, showing a huge posterior interosseous nerve and showing some edema inside the muscle. This is post-contrast, no announcement, a lipoma, the same sign, and it was operated, and everything is fine now. Intramuscular compression. This is not described in the literature. I found a lot of patients which has not the compression in the fossa, not proximal, but I believe more inside the tunnel, inside, in between the two muscle heads. This is one case. You see swelling here, the fossa is over there. And the most interesting thing, which is, again, not described in the literature, is the appearance of the muscle itself, the supinator muscle itself. This is longitudinal, and this is axial. The nerve, swelling over the nerve. So, what is the problem? Fat infiltration, hypertrophy of the superficial part, not of the deep. Because I believe the nerve is compressed inside the muscle. So the small nerves which go to the deep are preserved. And the distal branches to the muscle are compressed. And if you go back to the ultrasound, you can see here the longitudinal is exactly the same of my drawing. You have a normal, deep, and a wide, small, superficial. And this is the nerve which is compressed over there. And what I believe, since the superficial is fat and is hypertrophic, the deep became larger, compensation, which allows, again, compression of the nerve. And this is axial. Sorry. Look, this is the, sorry, it doesn't work. This is the same with the deep and the superficial in the normal subject. Black and black, this is black and white. It's quite interesting. It's not described in the literature. Not yet, I believe. If you do MRI, it's the same. A normal muscle over there, I'm cutting over there. Huh? I move a little bit distally. You can see a normal muscle and the fat degeneration of the muscle. I move a little bit distally, and the fat component becomes larger and larger. And this is the nerve, which is swollen. And this is the announcement after gadolinium injection of the nerve. The third type is the compression distally there is a good anatomic study from a French team discussing this. Sometimes there is a fibrous part also on the distal. Look to this case. The nerve is here. It's quite normal, quite normal, quite normal. And to the hand, it became thicker. It's not so large, but compared to the normal nerve, which is 0.5 maybe, 0.6, 0.7 millimeter, it's a very huge enlargement. Look to this. The nerve, very flat, and now large nerve, to the exit of the tunnel. So when you explore this nerve, please go till the exit of the nerve from the tunnel between the two muscles. This is very important. To the wrist. I have enough time? It's okay. To the wrist, I don't discuss the carpal tunnel, but I discuss a little bit the ulnar nerve. As you can see the splitting of the nerve at this level. This is the pisiform, splitting in two, or sometimes more frequent, three. One is the deep motor, two are the superficial for the fifth and for the fourth. And the artery makes more or less the same division. This is the proximal tunnel. You can see the artery, the nerve, the pisiform, the artery, the nerve. This structure is the transverse carpal ligament, which go inserting in the pisiform. And when I move from proximal to distal, you can see this type of arrangement. This is the hook of the mate. You can have one superficial artery, the superficial branch or branches, and this is the deep, which runs just under the muscle flexor digiti minimi at the level of the medial aspect of the hook. That's why it can be injured by fracture of the hook together with the small artery. So we will move a little bit. We start looking to the nerve first, not to the artery, to the nerve. I move distally from here to this level. And you can see this is the deep branch. You must focus just on this one. This is the deep branch. And it is located below the muscle and close with the artery, the nerve and the artery over there. It's always the same. Maybe a little bit superior, superficial, maybe a little bit deep, but it's always the same. And I come back now and I follow the superficial here. One and two, fourth and fifth superficial, and the superficial artery, as in the drawing. So in every patient, you can do that. Every patient. And you can squeeze, once again, the nerve trying to induce a positive tendon sign. You can find accessory muscle inside, but honestly, I have seen, I believe, hundreds of accessory muscle, never pathologic. It is well described in the literature when it is really hypertrophied, they can compress the nerve, but it's so unusual, so unusual. So this is the typical appearance of the muscle. This is the typical appearance of accessory abductor digiti minimi, the artery, the nerve, a small flattened appearance of the nerve, the transverse carpal ligament, and the muscle inside. And this is the MRI, the pisiform, the nerve, and the artery. Sometimes you can have compression because the muscle is located in between the artery and the nerve, which is not so unusual. Look this clip. You have in the artery, the nerve, and the muscle located in between. Once again, this is the medial nerve. Look to the artery, the accessory muscle, and this is the nerve, which is located and a little bit compressed by the muscle. And if I do a longitudinal over there, I can see the artery, superficial, the muscle, and when I move the nerve, which is a little bit compressed by this muscle. This is the nerve, normal, and compressed at this level. So it's very, very small details. Ganglia, the most common masses inside the Guyon tunnel. You have the artery over there and the nerve compressed against the pisiform. I injected the dye in the medial, in the radiocarpal joint. There is usually communication in between the pisotriquetral joint and the radiocarpal joint. So I put the needle inside, I injected the dye. And you can see here the ganglion, which is filled by the contrast I injected in the joint. And if you look to the 3D, you can see the ganglion exactly over there. This is the pisiform. And you have to image the nerve compressed in between the two. You can put a needle inside, you can aspirate the mucoid fluid without injuring the nerve and the artery under ultrasound guidance. This is the typical appearance of the ganglion. The nerve is once again here, the artery is here. And this is my needle tip, and this is after aspiration of the mucoid content and injection of a small amount of a steroid inside the ganglion. You can never know. The hand surgeon asked me to do that because they don't want to go for surgery after without trying an injection. Pseudoaneurysm of the ulnar artery, superficial ulnar artery, compressing or reducing the vascularization of the nerve, I believe, most probably. I put the transducer in this way. I can see here the artery, and you can see moving the thrombus is like the aorta, abdominal aorta, and one again, the artery, which is normal. The nerve is located close. So I don't believe, really, there is a compression, as everybody says. I don't believe that. It's like the persistent median artery, thrombosis of the persistent median artery in the carpal tunnel. It's not a compression. It's a reduction in the vascularization of the nerve, vasa nervorum. I go for the axial power Doppler. Exactly. You can judge the size of the thrombus and on the longitudinal also. This is the hook of the mate. Typical. The compression is against the hook of the mate of the superficial. Bicycle, too much. And you can see here a swelling of the superficial by chronic compression against the tip of the hook. This is the clip. You have the artery, you have the nerve, and you can move a little bit distally to the hook of the mate. You can see a huge swelling, huge of the nerve. Right on the tip of the hook. And you squeeze a little bit, yes. And this is the motor branch, which is completely normal. Look at the difference in between this one and this one. And this is the flexor digiti minimi insertion. Ganglia, once again, the nerve, the deeper branch. Look at the deep branch at the ganglion. So a compression of the deep branch. If you make a longitudinal, you can see the branch going down, displaced by the ganglion. This is the nerve. And it's swollen and hypoechoic. And as usual, correlation with the clinical findings. Usual, every time. The radial nerve, distal part of the sensitive branch. We see that the nerve comes down to the anterior aspect of the forearm and then go up the tendon of the first extensor compartment to innervate the dorsum of the hand, the radial head. This is the tendon of the extensor compartment. First, the nerve comes like this. That's why in the decurventinous synovitis you can have a problem of this nerve. This is the radial artery, the snuff box, and this is the cephalic vein. And as you know, the nerve runs close to the vein, very close to the vein, and this is the problem. Why? Because when you put a needle in the cephalic vein, the vein dislocates. So you have to fix the vein. They do every time that. They fix the vein and they put the needle inside. They fix the vein and the nerve, and they put the needle inside the nerve. When I was a student, I said to myself, this vein is bizarre with this vein. It is painful, the vein. No, it was the nerve. I put the needle inside the nerve. I have a lot of cases. This is the nerve. This is the vein. These are the extensor tendons. This is the radial, distal head. And I move once again from proximal to distal. You can see the nerve, normal, normal, once again, normal, normal, close. You can see the fascicle inside this nerve, which is 0.5 millimeter, normal. And going below on the other side, completely normal. So we can judge the nerve. You can judge the nerve, you can judge the fascicle inside the nerve. Huh? And this is the poor lady. Look to the gel. I put a lot of gel because it was painful. Just looking with my transducer, it was painful because there is a neuroma. So I have put a lot of gel. This is the same in the nerve, but this side the nerve is swollen over there. And I'm normal. Swollen here. Look. A normal nerve and a swollen nerve. And I push a little bit more. Yes, this is the site, the location of my pain, radiating down to the hand. And so what you can do now, in the last month, I made a sign on the skin just for the hand surgeon. Now, I ask the patient to take the iPhone. Everybody has an iPhone. I don't move the transducer, and she can take an image, a picture, to show to the surgeon. This is the location of my neuroma. It works so well. And sometimes, very well. And sometimes they ask me to make an injection. To make an injection around the neuroma. I use a 27 needle. 27, you don't feel the needle entering the skin. 27 is the dentist needle inside the hand. This is the nerve. This is the nerve. Huge swelling and normal nerve. This is my needle, and this is the nerve, the neuroma. I don't have the centimeter over there. It's too large. So you can see my needle, the neuroma. I'm okay. I am close, just under the neuroma. And I can inject. There is just fluid. This is the nerve. This is my needle point. I can inject all around. Some anesthesia. Look at the nerve. Just to block the neuroma and to confirm the diagnosis, and then to locate exactly this. Very, very quick, the palmar sensitive branch of the medial nerve is this small branch that go outside the carpal tunnel, can be injured during the section. Is located with the flexor carpi radialis and the medial nerve, and at the level of the carpal tunnel, it can be inside the ligament or superficial to the ligament. 1, 2, 3. Normal, injured, normal. The nerve, normal, normal. Wait a minute. No, it's a normal case, sorry. Voila. This is the injured case. This is the nerve. Look, very, very, very small. Normal, swollen, swollen. 5 times the surface. Is 1.1 millimeter, means it's 5 times the normal. Cut during the carpal tunnel release. And this is an image, the normal nerve, superficial branch flexor carpi radialis, my medial nerve, a little bit swollen, surrounded by the fibrotic changes. You can see the nerve, but it's swollen proximally, and is normal distally. So there is no doubt. And usually it's very, very annoying because you have no sensation over there, and some paresthesia, painful paresthesia over there. The branch comes from here and go to this. So, in conclusion, ready to use everywhere. you have an equipment, cheap. The only problem is to form the sonologist. Quick, you know, quick. If there is somebody asking, look to the median nerve from the axilla to the distal branches, I can do that in 3, 5, 4 minutes. If you have to make MRI, you have to change the position of the patient. It's really quick. It's really panoramic, non-invasive. You discuss with the patient, we talk with the patient, and you make the examination in the same time. Panoramic. You can do that. You can make all the nerves in 10 minutes of the upper. Dynamic. You can move, flex the elbow, see if there is a dislocation of the ulnar nerve, move the muscle, see if there is impingement, move the supinator, see if there is an impingement posterior. It's very good. You can press to see if there is a tunnel sign. And lastly is really very elegant, really very elegant. Thank you very much for your attention.
Thank you, thank you. Are there any questions from the audience? Flabbergasted. Yeah.
So there is no normal variety in thickness of nerve. Every thickness.
You know, I am from Italy. This is the answer. I know, I understand well. You know, but what I do usually, I take the shortcut. I look to the other side, but it's not so frequent. I saw hundreds of thousands patients. So I put the transducer, and I can see if there is swelling, yes or not. And I compare to different levels, which is the most important. I usually do the clinical together. So I just start examination with my clinical diagnosis. I was for 10 years a rheumatologist before starting to be a radiologist. So I make my short physical examination, I make my diagnosis, and I try to confirm yes or not my diagnosis. So it's easier to me. I understand it's not very scientific, I understand. But you know, if you start measure, you never know if you have to measure the outer part, hyperechoic part, yes or not. There is a lot of confusion about that. Huh? The size, the value, the shortcut value differs a lot also. 14, 50, it's very difficult. I do that. So I examine the same nerve with the knowledge that the nerve must become smaller and smaller and smaller and smaller going to the periphery. I look to the structure. I compare to the clinical findings, and sometimes, not so frequently, once in a month, I look to the other side. It works. It's not very scientific, I know, but it works very well.
Are there other questions? And if so, please try to use a mic.
Do you think that the ultrasound might replace EMG as primary modality?
There are some patients in which there was a clear clinical problem. There was a positive EMG and a negative ultrasound. I have to say this is true. Particularly during ankle sprain. You know, ankle sprain, the patient comes with a foot drop. It's clear. You look to ultrasound, nothing. So I know there are some patients that are positive but negative to ultrasound. When I start the examination, I start always with the same sentence to the patient. You make the EMG, the neurologic studies. This is function. I can tell you morphology. It's not the same things. So the surgeon must have the two, probably. But it's exact. Sometimes it's disappointing. It's disappointing. But I can locate, you can see, I can locate when there is a compression very, very precisely, the site of the compression, very precise. So what they ask me, just for the ulnar nerve, is there a compression? Is there an extrinsic mass? Yes or no? Is there an instability? They ask.
Anybody? Yeah.
Congratulations, Dr. Bianchi. Congratulations.
Thank you.
What do you think is the most important responsible of the luxation of the ulnar nerve in the Switserland? The accessory muscle or the normal muscles?
No.
Can
It's the rear.
you repeat the question for the
Yes.
audience?
So if I well understood, the question was, when there is instability of the ulnar nerve, the most frequent problem. What I believe is anatomic problem is absence of the retinaculum. I have this on the left, on the right side, myself. So I have problem. I have no mass, no cystic, no accessory muscle. Simply, there is no ligament. And when I drive in this position after 2 hours, I have the problem. So the muscles are quite infrequent. And what I say every time to the patient, I am not sure that the muscle is the problem. Sometimes it's not a problem at all. There is instability in the muscle which is inside the tunnel. The surgeon are very happy when I find the muscle. So they can go to surgery. But I'm not so sure 100%.
I have one small question. When you showed us a lot of swelling, can you say that the swelling is just beneath
No.
or does it continue to more distal?
There are two types of swelling. The first is more common is proximal. This is well known, proximal, the pseudoneuroma of the medial nerve. But a lot of times there is swelling distally. The copper head in the median nerve compression, the longitudinal, you can see the median is swollen, very thin, and then again swollen with a copper head appearance in the longitudinal. So I don't know exactly why. But I know very well that you have to go outside after the compression, before and after, to judge.
Stefano, you showed us a marvelous presentation. I'd like to thank you for. But from my own experience, I know it looks easy, but it isn't. So can you tell us something about the learning curve?
Now it's 34 years that I do that. 34 years.
That's a learning curve.
That's a learning curve. The most important things, I believe, you must like it.
Yeah.
You must like it. There is no other way. You must like it. So if the guys comes, you can see in a few seconds there is nothing. There is no local problem. You start examining the anatomy. You start seeing, well, let me see if I can see this small nerve over there. Let me see if I can see this variation. So the patient is very happy because you close or you look in the deep. And every patient I do 30, 35 patients, just musculoskeletal, every day. And if I was, I was anxious to make some ultrasound because from 2 days I have not touched an ultrasound machine. So you have to do that. Nil die sine linea, Latin. No 1 day without writing a line. Otherwise, you lose something. So you have to
practice, do it often.
To practice, and to like it.
Yeah, and know the anatomy.
And anatomy, oh la la. Yeah. Anatomic variation.
Yeah.
When you start anatomy, you don't study anatomic variation. When you start ultrasound, you say, what is this? Anatomic variation? What is this? Anatomic variation. Beefy nerve, beefy tendons, muscle which are normal. I know there are a lot of anatomic variation. So yeah, with years, we start to have a very clear idea of every structure in every plane, in every level.
Yeah.
But it takes a little bit.
Okay, thank you. If there are any questions left, then I will invite you for a small break. I'll see you back in 25 minutes.
Thank you.